Greetings. So today we will follow up from last week, and we'll first talk about some more advanced means of diagnosing patients from a laboratory testing point of view. I'll just really give some examples of studies that have shown the impact of those types of newer innovative methods. I wouldn't expect you to be able to explain to me what is MALDI-TOF and how does it work. So it's more just showing you examples of the impact that these newer diagnostic methods can have when it comes to improving clinical outcomes, making for more efficient and appropriate use of antibiotics, also improving patient outcomes, mortality, etc. So then we will talk about MIC testing and how we do MIC testing and how we interpret MIC testing. I was then going to have you get into groups and basically have representative MIC reports and kind of work through how you would interpret those, but I think we'll just do it as a group, basically. So I'll post some examples of different MIC tables and how we would interpret those, and you'll have to tell me how you want to treat these patients. So we'll go through that. Then I'll show you some examples of some of the MICs that you did the other day, just to kind of show you how we read those and to show you some of your results. Then we will go upstairs again, and so I have all of your plates from the other day all lined up in the Hannaford lab for you to take a look at, so you can see the results of what you did on Monday. So it'll be a shorter day, I think, today, if that's okay. Again, thanks to you guys, especially who stayed till the bitter end and past 5 o'clock doing MICs on Monday, so I hope it was at least somewhat worth it. So I think we'll have a shorter day today, but I guess I should start if that's going to be the case, right? So again, this slide just shows some of the varied methods that we now have for more sophisticated ways of doing diagnostics when it comes to infectious diseases. Many of these are genetics-based, not all of them are. We'll talk about some of the different examples. I think really the main things that these offer would be more timely results. So again, we went through that example of a traditional culture-based methodology which can take days, sometimes even weeks, to get you good results that you can use clinically, and often while you're waiting for those results, as in the case of HK that we talked about, it's too late anyway. So these all tend to offer more accuracy in general, more rapidity in general, so really these are the wave of the future, I think. So the value of these tests, so you certainly can have clarification of an infection, and so these would be a way to diagnose the condition that someone has. So often you don't know exactly if someone might have, do they have pneumonia, do they only have pneumonia, do they have other things going on as well. So some of these diagnostic things will be useful just for determining what infection the patient actually has. They also are very good at establishing what is the actual etiologic agent, and we'll go through some examples, for instance, of diagnostic tests that are specifically designed to identify MRSA infection and to do so in a more rapid manner. And so you know very early in the course of therapy that someone has MRSA and you can adjust your therapy accordingly. That then leads to determining the optimal therapy as well. So if you know someone has MRSA, there's only certain drugs that you can use to treat MRSA, and so you're presumably providing someone a more effective therapy based on those results. I'm not going to talk about them today, really, but there are some other diagnostic tests that are really geared especially towards optimizing therapies. One notable example of that would be that one of the therapies that we use for HIV depends on a certain phenotype of the HIV virus being present, and so before you would start that agent, it's called Marivaroc, you'd have to do what's called HIV tropism testing, and that would tell you essentially whether you could use Marivaroc or not. And so that's an example of a very targeted therapy-based type of, not really diagnostic test, I guess, but more a test that allows you to determine whether you can use that drug or not. These diagnostic tests are also important in antimicrobial stewardship. We'll talk about one example of that. So antimicrobial stewardship is very in vogue right now. Most hospitals will have antimicrobial stewardship teams of pharmacists, nurses, physicians who really their job is to police the use of antibiotics and make sure antibiotics are being used appropriately and rationally. And the information that we can get from some of these newer diagnostic tests also often helps in antimicrobial stewardship by helping us to use rational, effective drugs, not using super broad spectrum agents when we can use more narrow spectrum agents. These are also important when it comes to public health surveillance, and so when we're doing epidemiologic studies, trying to do, for instance, investigations of outbreaks, for instance, these types of tests will help with that. And then finally, many of these tests are being increasingly targeted towards doing so-called point-of-care testing, and so testing out in the field where you can go to a patient's home and do, for instance, testing to see if they have the flu or not, and so you avoid the need for the person to go into their doctor's office and get that test done. So certainly there are many tests that can't be done as far as point-of-care testing, but more and more we're trying to figure out ways to do that point-of-care testing out in the field. As far as barriers to the use of newer diagnostic tests, as you would expect, these things tend to be fairly expensive in many cases, and so one of the testing methods that we will talk about later on, which is rapid time PCR, just buying the system that would allow a hospital to do rapid time PCR testing in their hospital costs $35,000 or more just to have that unit basically sitting in the microbiology lab. So these things are definitely expensive often. For that reason, we often don't see these used in resource-poor countries where, unfortunately, we have probably more of a need for these types of things. They also sometimes suffer from availability problems as well, and especially, again, in resource-poor countries where you can't just go out and buy a bunch of PCR machines and have them laying around for point-of-care testing. We sometimes do develop tests that end up addressing clinical needs that really aren't terribly important and that aren't going to really necessarily really guide our therapy or change our outcomes too much. And so, for an example, there's a test that is derived from the blood of horseshoe crabs that we can use to diagnose or help in the diagnosis of meningitis. The results of that test don't really change your therapy one way or the other. So the end result is what really was the value of doing that testing methodology and hurting poor hermit crabs, or not hermit crabs, hermit crabs. So that's just one example where sometimes if a test really doesn't help us clinically and it doesn't really have that great of a need, then what's the point of it? So horseshoe crabs are not hermit crabs. And they're not actually harmed in the making of that assay. So their blood is harvested and they go back to living in the wild. So anyway, also there's a lack of integration. So sometimes really providers need to get into the habit of using these types of newer diagnostics, and often they don't, and so they just don't really embrace the use of them. We don't have them really worked into the typical pathways that patients would go through when they get admitted with different infections. Also, there's a problem of lack of knowledge, and so for instance, PCR-based methods, looking at DNA sequencing and things like that, that requires a certain amount of expertise when it comes to interpreting those results, and so if your providers don't know how to interpret those results, then really what's the point of using that test? Unfortunately, many of our clinical guidelines take a long time to embrace the use of these newer diagnostics, and so for instance, the current IDSA guidelines for the treatment of pneumonia, they really don't give much priority to many of the newer diagnostic tests because they feel like there hasn't been enough adequate studies done or there's enough adequate evidence to show that they have a great impact on therapy. And so if your national approved clinical practice guideline isn't saying to do MALDI-TOF, for instance, then it's going to be hard to justify doing that. There's also regulatory obstacles, and so many of these things have to be approved as devices, for instance, by the FDA, and there's sometimes a lag as far as getting that done. So just as a reminder again, sensitivity and specificity, so I'll talk a little bit about that again. And so our ideal test would be 100% sensitive and 100% specific. We don't often see that, unfortunately. So again, remember spin and snout. So a sensitive test helps to rule out the disease, and so it's going to detect that condition in most patients that have the condition, and then a specific test is specific for that condition, and so if you have a positive, that helps to rule in a disease. So spin and snout is a way to remember sensitivity and specificity. And unfortunately, some of these newer diagnostic methods do have, for instance, fairly low sensitivity and specificity. One example would be rapid strep testing to identify strep throat in patients. It's very fast and does a good job of rapidly identifying patients who have strep throat so that you can then either give appropriate antibiotics or withhold antibiotics, since often strep throat, or rather conditions that look like strep throat, don't require antibiotics. The bad thing about that testing is that it has very poor sensitivity and specificity, which limits its usefulness. That's just one example. So we'll talk about a little bit about all of these different methods, and really I'll just kind of give examples of some of these different types of techniques and how they've been shown to be useful. So first, when it comes to culture media, I just wanted to make the point that we talk about culturing patients, and so with HK, we talked about culturing her sputum, culturing her blood. I think one important point is that culturing definitely is not 100% effective or reliable, and so, for instance, you have to make sure you're using appropriate media, and so all bacteria don't grow under all conditions or all media, and so this is just one example, and so this agar is what's called chocolate agar. It doesn't actually have chocolate in it. It has hemoglobin in it, and hemoglobin solution happens to look exactly like chocolate milk, basically. And so the organism here is Neisseria gonorrhoeae, and so Neisseria gonorrhoeae requires some of the substances that are in hemoglobin to grow. And so if you tried to grow Neisseria gonorrhoeae on, for instance, the kind of agar that you guys were working with on Monday, you would see nothing, basically. And so you have to have, at least in this situation, you'd have to have some inkling that a person had Neisseria gonorrhoeae and choose an appropriate medium. There are other examples as well of media that are required for certain so-called fastidious organisms that require special requirements to grow and special media to grow, basically. An example of a sort of rapid diagnostic method would be so-called chromogenic media, and so there are a variety of different media where if you inoculate them with a sample from, say, a patient's blood, there are certain chemical means so that certain organisms will grow a particular color. And so if you have a normal plate, sort of like the agar plates that you guys are again working with on Monday, and you just streaked a bunch of bacteria on there, just looking at the bacteria, you wouldn't really know what's what for the most part. You might have some sense of what certain things would look like. So for instance, gram-negatives look different than gram-positives, but you really can't say, okay, based on this plate that's growing colonies on it, that this person has whatever. Whereas this particular medium, for instance, is a chromogenic medium that allows the detection of MRSA, and so MRSA grows a particular color, and so just seeing colonies with that color would tell you, okay, this person has MRSA, and so you're kind of reducing the timeline of knowing that someone has MRSA by using these types of chromogenic media. This is just one example. There are a lot of different other chromogenic media that are designed to show you that a certain organism is growing. There are also selective media that are designed to selectively show certain organisms. So again, you'd have an idea earlier on that someone had a certain pathogen that was infecting them. A lot of what we're going to talk about is our methods that involve either DNA or RNA. There are a variety of different ways of doing that. Most of these are PCR-based testing methods. Have you learned much about PCR? Maybe if you've done Dr. Brazeau's elective. Has anyone done Dr. Brazeau's elective? So you've learned PCR. So PCR really involves just designing pieces of DNA that will match up with a target of interest. And so you basically, if you have a positive match, then you know an organism is present. And so if you design, for instance, a chain of DNA that will, or of base pairs of DNA that will match up with the DNA of Neisseria gonorrhoeae, then you know someone has Neisseria gonorrhoeae. And so one of the currently recommended ways of diagnosing gonorrhea is exactly that. So it's a nucleic acid amplification test that will match up with someone's sample if they have Neisseria gonorrhoeae DNA in that sample, basically. So this just shows some of the different examples of that. So basically, you're kind of hybridizing DNA and looking for matches with certain organisms. And we'll talk about examples where you design PCR testing methods that will only detect one organism, which is a little bit limited. At the end of the talk here, we'll talk about next generation sequencing, which really one advantage of that is that you're testing for lots and lots of different isolates all at once. And so this is just sort of an overview of DNA-based methodologies. Certainly don't worry about knowing the details of this slide. So here's a clinical example showing outcomes in patients. And so this is a quantitative PCR, which will not only match up with the organism of interest, it will also tell you how many of that organism are present in a patient's sample. And so this is a clinical study showing the use of rapid or real-time quantitative PCR that was used in patients who had community-acquired pneumonia. And so these patients who presented with community-acquired pneumonia, their sputum samples were taken, there were samples of their sputum that were obtained, and the sputum was used or was exposed to this rapid quantitative PCR. And so what they were looking at was a specific PCR-based method that was looking only at Streptococcus pneumoniae. So that example of using a very targeted method that looks only at one particular organism. The table here shows different methods and the number of patients in whom there was a positive diagnosis of infection with Streptococcus pneumoniae. So for instance, you can see blood culture, only 20% of patients were correctly identified to have Streptococcus pneumoniae. Urine antigen, so there's a urinary antigen test where you take a urine sample and you test for antigens against Streptococcus pneumoniae. It's a fairly common test, but still fairly low reliability as far as diagnosing patients. And so you see the sputum culture, the RQ-PCR there, almost half of patients who had that methodology of testing were found to have Streptococcus pneumoniae. So showing really better precision or sensitivity when it comes to this RQ-PCR as far as correctly diagnosing patients who had Streptococcus pneumoniae infection. Here's the same study basically, and showing results as far as, again, the percent of different patients for whom there was a positive diagnosis of Streptococcus pneumoniae. So similar data from the previous table, but just showing it in a different format. So again, you see blood culture, urine antigen testing, traditional sputum culture and growing the organism on agar plates, and then sputum RQ-PCR, which had the best yield. And so an example of one of these newer diagnostic methods having a better ability to accurately diagnose infection in these patients with community-acquired pneumonia. So that's detecting one organism, which certainly has its values, but can be a little bit limiting as far as we often don't necessarily think that or suspect that someone might have one organism. There might be multiple organisms that are potentially causing an infection in someone. So there now are multiplex PCR and other types of PCR that are designed to tell you whether someone has any one of a number of different organisms. And so this again is patients, this is a clinical study again of patients with community-acquired pneumonia. Again, there were a variety of different diagnostic methods, including traditional blood cultures, traditional sputum cultures, cultures of nasopharyngeal secretions, then again, an analysis of sputum cultures or sputum samples by real-time quantitative PCR, again, serologic testing, and also urinary antigen testing. And so in the table there you see, again, for a variety of different pathogens, the number of patients basically, or the yields of these different types of diagnostic methods. And so on the right there you have PCR, for instance. Next to that you have serology. Next to that you have traditional nasopharyngeal secretion cultures. And so, for instance, for rhinovirus, you see that neither nasopharyngeal cultures nor serology were able to diagnose rhinovirus, yet you had 12 instances where using that PCR you were able to diagnose rhinovirus. So again, from an accuracy or sensitivity point of view, an advantage of the PCR-based methodology. This is data from the same study looking at a variety of different organisms. These types of PCR methods are often particularly useful with infections that are caused by viruses, because viruses are hard to culture, they're hard to do other testing of, and so PCR-based methods are definitely great, especially for viral infections. And you can see here, this shows detection of a variety of different bacterial pathogens, but also a variety of different viral pathogens. So really, I think, as shown by these two studies, at least nowadays, we don't traditionally avoid culturing in favor of PCR. I think PCR becomes a part of the battery of testing that you do, and certainly we still do culturing, we still do serology, we still do urinary antigen testing, and this just becomes a piece of the puzzle. There might be a time when we only do PCR and we don't do any of these other methods, but I think other things like culture still are at least a part of the diagnostic workup for most infections. So this is real-time PCR to specifically detect resistant pathogens. And so these are all patients with Staphylococcus aureus bacteremia, so they have Staph aureus growing in their bloodstream. That's a fairly serious infection that's somewhat difficult to treat. So this rapid PCR-based methodology was designed to specifically detect MRSA. And so what these investigators were trying to get at was, when it comes to Staph aureus infections, if you think someone has MRSA, you typically would empirically start them on vancomycin. However, if you find out that the person has MSSA, the question becomes, do you still need to treat them with vancomycin? You don't, because there's lots of other options to treat MSSA. Those other options to treat MSSA are better drugs than MRSA. So if someone has you suspect MRSA, you start them on vancomycin, you find out they have MSSA, there's a lot of advantage to getting rid of vancomycin and changing to cephalosporin, for instance, or a penicillin. And then the same thing is true for MRSA. Daptomycin is a better drug for MRSA than vancomycin in many situations. And so basically this is showing, in the black you have a cohort of patients before this institution adopted this PCR methodology, and then in the gray bars you have the kind of post-PCR methodology, or patients basically, and you see the number of patients who were switched, in the case of MSSA, from vancomycin to either cefazolin or nafcillin, and in the case of MRSA, who were switched from Dapto to, or from Vanco to Dapto rather. So I think especially if you look on the left, after this PCR-based method was used to quickly diagnose patients with MRSA, you had a much greater number of patients who were correctly switched to that superior therapy, basically. This shows the timing by which that was done, and so the point of this slide really is, again, the gray bars are the period of time after this institution started doing PCR-based methods. The black bars are the before period, and so as you see, the mean time to make that switch was also shorter after that PCR-based method was started. And so essentially the point is that knowing early on in the course of therapy that someone has MRSA allows you to more quickly switch to a better therapy, and that leads then to better patient outcomes. And this study showed, for instance, better outcomes as far as 30-day mortality, also reductions in costs as well. So a variety of different positive outcomes from what is a relatively expensive methodology. Again, this RT-PCR is about a $35,000 piece of equipment, and then you have the individual tests, which are not inexpensive either. But when you look at the appropriateness of therapy, the benefits of that outweigh the costs of just the testing method by itself. Any questions so far? This shows MALDI-TOF, which is a newer methodology. This figure is from a publication by the IDSA. So the IDSA not only is doing a lot of work trying to convince the government to do things like helping to expedite antibiotic approvals, they're also trying to promote the government as far as approving these newer diagnostic methods, basically. And so this is a spectrometric methodology, basically, which tells you exactly what someone is infected with. And so MALDI-TOF, for instance, can tell you that someone has infection with blank organism, basically. So a very sophisticated methodology, as you can see, or maybe you can infer based on the size of that thing, not a point-of-care based method, certainly, but a very fast and also accurate way of diagnosing infection with particular organisms. So this is a study showing whether using MALDI-TOF can improve outcomes. And so this is looking at patients who had antibiotic-resistant gram-negative bacteremia and using MALDI-TOF earlier in the course of that patient's clinical course to accurately diagnose that gram-negative infection. And so this particular slide doesn't show outcomes, but you can see the timeline. So that upper bar is the period of time before this hospital started using MALDI-TOF. The bottom line is the period of time after they started using MALDI-TOF. And so you can see that if you look at that top line, that red dot on the very far end, right end of the timeline is when you would adjust therapy when you find out that someone has gram-negative resistant pathogens. Whereas if you look at the MALDI-TOF line at the bottom, you see that you have the ability to adjust your therapy much, much earlier. And so presumably you're adjusting therapy to give patients the right therapy based on that resistance. So again, the point of this is that you're knowing much earlier in someone's clinical course that they have a resistant pathogen causing their infection, so you can give them the right antibiotics earlier in the course of therapy, which, as this study showed, also leads to overall reductions in cost because you're using the right drugs, also causes earlier discharges, better 30-day mortality, so a variety of different benefits from using this particular methodology. Next would be next-generation sequencing, and so next-generation sequencing is essentially very much like those other PCR-based methodologies that we showed. So for instance, the PCR-based methodology of diagnosing Streptococcus pneumoniae, but next-generation sequencing basically blasts tons of different organisms, and so you're detecting a huge number of organisms in a patient's clinical sample, which increases your diagnostic yield. So this is the sort of the last example that I'll show you, and then we'll talk about MIC testing. And so this was a publication from 2014, made the national news quite a bit as well. So this was an individual who had meningitis-like symptoms for a rather prolonged course, and so you can see over a year during which this patient was essentially undiagnosed with his infection. He was having extremely serious clinical outcomes from this infection. At one point, had to have a brain biopsy, which, as you'd expect, is not something that you would do lightly in a person. Was also at one point put into a medically induced coma to help with the symptoms. And throughout all this time, all of the cultures were negative, all of the serologic testing was negative, so there was absolutely no idea what was going on with this patient, who in the end was very critically ill for a prolonged period of time. This shows a little bit more of sort of his outcome, and so you see a variety of different testing. So there were MRI testing done on the left there. You had brain biopsies, which failed to show anything. You see there the period of time when the person was put into a medically induced coma to help with the treatment of seizures. You see a variety of different antibiotics were used. So MEP, CFX, CFPM, VANC, and PCNG are all different antibiotics that were used. All had no outcome as far as helping this patient. And so really these investigators or these clinicians were basically at a diagnostic conundrum and didn't know what was going on with this person and weren't able to cure this person. So then they did next generation sequencing. And so you see there on the left the percent of sequences for which they had a positive hit in the patient's central nervous system fluid. And so you see the large number of hits for Leptospira species. Then on the right, you see the advantage of these next-generation sequencing tests, where not only can you detect Leptospira, you can detect all sorts of different serovars and subtypes of Leptospira. And so it wasn't until this testing was done that this patient was diagnosed with CNS infection caused by, or CNS leptospirosis, basically. The patient was given a very short course of penicillin, which completely cured the patient, and he was basically back to new after that course of therapy was done. So just showing the usefulness of these types of testing as far as solving these diagnostic conundrums and helping in that way. And then finally, just a cautionary tale, I guess, as far as can we sometimes have more data than we need. And so let's pretend we have HK again. This time she's been in the ICU for 4 weeks, was brought through the ER with pneumonia, febrile neutropenia, received a 14-day course of therapy for her pneumonia, so her pneumonia was cured essentially. Her neutropenia was also resolved. She's been in the ICU, however, because she hasn't really been totally hemodynamically stable, has still required some supportive care. In the intervening weeks, she's had some intermittent fevers, some elevated white counts. All of her cultures have been negative, but because we're concerned about her condition, she's still been receiving antibiotics even in the face of negative cultures. So she's receiving piperacillin, tazobactam, and vancomycin for the past 10 days. Really, probably for perhaps no reason, but just because she's critically ill and we're not really sure what's going on, so we'll keep her on antibiotics. So you're the primary care team taking care of this patient. You order an ID consult to ask for help in how to manage this patient. Often when you order ID consults, ID physicians tend to be fairly good stewards of antibiotics and don't want to use antibiotics when they don't need to be using them, and so your ID physician tells you to stop antibiotics. The team reluctantly agrees, but they decide they want to order a procalcitonin level, and so procalcitonin is a general marker which in some studies has been shown to indicate the presence of infection a variety of different ways. So 3 days later, you've stopped antibiotics. However, your procalcitonin level comes back as 0.4, which according to the guidelines would indicate the possibility of infection. So the question is, what do you do in this case? This person is improving without antibiotics. Because of this procalcitonin level, do you want to restart antibiotics? And there's not really a right or wrong answer to that question, but I think the point of this is that sometimes you can get information which just complicates your decision making and doesn't really give you a clear answer. And so this is an example where procalcitonin has been shown in some studies to indicate infection is not terribly sensitive or specific. So you've kind of muddied the waters by doing this procalcitonin level in this particular patient. So just sort of a cautionary tale that getting good diagnostic information is valuable, but sometimes if you get too much information, if you don't know what to do with it, it can make things perhaps even more unclear. So any questions about those different kind of just a snapshot of some of the newer ways of diagnosing patients with infections. All right, so lastly, antimicrobial susceptibility. So an example of an MIC test would be the following. I showed this the other day, I think. So again, you have these varying concentrations of, in this case, ciprofloxacin. You are testing, in this case, an MIC to E. coli, and so you have these different tubes set up with different concentrations. You inoculate them with E. coli, you incubate them overnight. You then look for visible growth. Here you have visible growth up until a concentration of 1 milligram per liter, and so the end result of this test basically is that your MIC is 2 for this particular isolate. And so I posed the question the other day, knowing only that information, can you treat this patient with ciprofloxacin? And the answer, of course, is that you need more information to do so. So what you need to know are your breakpoints. So here again are breakpoints for Enterobacteriaceae, for fluoroquinolones, and so essentially the breakpoints would tell you what is the MIC that corresponds to a finding of susceptible or intermediately resistant or resistant. And so in this example of E. coli, which is a member of the Enterobacteriaceae family, your ciprofloxacin breakpoint for considering the organism susceptible to cipro is less than or equal to 1. And so in this example, where we have this MIC of 2, your conclusion basically would be that this isolate is not cipro-susceptible, and I probably can't use cipro to treat this isolate. So what do these breakpoints mean? So susceptible implies that the isolate basically is inhibited by the usual concentrations of the antibiotic, assuming that you dose rationally and appropriately, you give the correct dose, you don't underdose, you account for PK changes, you account for weight changes, you use a drug that is active at whatever site of infection you're treating, and so if you have a UTI and you have an isolate that is susceptible to a drug that doesn't get good concentrations in the urine, then you're not going to have a good clinical outcome. But assuming you use your drugs rationally and use them correctly, if you have that finding of an S next to your drug, then that should imply that you would likely have clinical success, again, not guaranteed. Then you have intermediate resistance, which really we call dose-dependent or concentration-dependent, and so if you can increase the dose of your antibiotic to get higher concentrations, then you might be able to treat an isolate that is intermediately resistant. We often can't do that when it comes to antibiotics, and so we, for toxicity reasons, we can't typically give higher than normal doses. So the concentration-dependent part of this becomes if you're treating an infection where you get really good concentrations of that antibiotic, such as TMP SMX in the urine, you could probably still get away with treating an isolate that was classified as intermediately resistant. And then finally, resistant would imply that if you use that drug, you're going to likely have clinical failure. I'll skip actually this slide. So we'll go to a patient-specific report of MICs, and we'll go through a few of these, and I'll have you interpret them and choose therapy for some patients. And so here's a patient-specific report. So we have a guy, John Doe. He has E. coli. This is a urine culture isolate. You see your different antibiotics. You see your different MICs that were found in this test. And then according to the breakpoint values, you have what are the different interpretive categories. And so when you're interpreting these, basically, you look for things that are R or I or S, basically. And so in this situation, appropriate therapies for John Doe would be meropenem, amikacin, fosfomycin, and nitrofurantoin, because the isolate is susceptible to those agents. And you wouldn't want to use ampicillin, for instance, because the isolate is resistant to ampicillin, and so if you used ampicillin, the likely outcome would be treatment failure. So any questions on interpreting those reports? All right, so we'll go through a few of these in a couple of minutes here. I first wanted to show you some examples of your MIC tests from the other day. So when you swabbed the agar plate, basically, if you had done nothing more than that, you would have had a lawn of growth across the entire plate. But because you put those E-tests down, you have your E-tests, the plastic strip where the antibiotic diffuses out of the strip. You have higher concentrations at the top of the strip, so you have a larger zone of inhibition at the top where you have those higher concentrations. And again, E-tests are called that because they have this ellipse that forms of growth, or of rather inhibition of growth. And so the way that you would read this MIC is you would look for where does that line of growth cross the E-test, and what is the corresponding number there. and that is your MIC basically. So each one of these e-tests is an individual drug. Any guesses as to what this drug might be? So oxacillin, yes. This particular isolate is a Staph aureus isolate. So would this be an MSSA or an MRSA isolate? So it'd be MSSA, right? So this is an MSSA isolate. I would say the MIC, it might be hard for you to see, is about probably 0.38, which is a very low MIC. I don't know the breakpoint off the top of my head for Staph and oxacillin, but I think this would probably be well under that breakpoint, and so this would be considered to be an oxacillin susceptible Staph aureus isolate. So is that clear? So just a few more examples of this. TS, any guesses as to what TS means or stands for? So TS is trimethoprim sulfamethoxazole. And so this is happens to be an MRSA strain, so would you think this is more likely to be a hospital-associated MRSA or a community-associated MRSA? Community, right. So remember that Bactrim, just like macrolides, just like more like tetracyclines, also Clinda, better activity against community-associated MRSA. So this is an example of a community-associated MRSA. Very low MIC, I would call that MIC. It looks like about 0.064 milligrams per liter. Very, very low MIC and well under the breakpoint for TMP-SMX. And so again, this isolate would be classified based just on only on this value here, would be a susceptible isolate that you could use TMP-SMX to treat, again, assuming you use the right dose, etc. So any ideas what AT might stand for? Any guesses at all? So AT is as treenam. So if you see, there's absolutely no inhibition zone around this strip, right? So basically so as treenam had zero activity against this organism. So your conclusion based on this test would be that the MIC is greater than 256, which is the highest number on this e-test. And so based on this result, would you think that this is a gram-positive organism or a gram-negative organism? Hearing some positive. So remember, as treenam is active against only gram-negatives, no gram-positive coverage. So this happens to be another Staph aureus isolate. This is PTC is piperacillin tazobactam, and so this happens to be an E. coli isolate, a very susceptible E. coli isolate, and so the question becomes, and so this isolate is susceptible to piperacillin tazobactam. Do you think if someone had an E. coli infection that pip-tazo would be the best option for that patient? Probably not, right, because it's a little bit more, it's that scenario of dropping an atom bomb on an ant, I would say, when it comes to using pip-tazo. But this would be the first plate that shows E. coli. Pseudomonas has a very characteristic kind of bluish green color, and so this plate is full of Pseudomonas, and even the agar kind of gets this hue of green-blue kind of around it. And so this is Ampsilobactam, and so I guess I don't need to pose the question of is Ampsilobactam an agent that has activity against Pseudomonas, because as you can see, there's absolutely no zone of inhibition around this Ampsilobactam E-test. This is also Pseudomonas, IP. Any ideas what that might stand for? Imipenem, I think I heard maybe. So yeah, imipenem. You also see no zone of inhibition right around this isolate, or rather the strip. Should imipenem have activity against Pseudomonas? Is it on that list of drugs that cover Pseudomonas that we talked about in therapeutics? So it definitely is. So imipenem should have very good activity against Pseudomonas. So why is there no zone of inhibition around this E-test? It's upside down, right? So, it's probably was happening maybe later on as we were rushing through and I wasn't giving you enough attention. So this is an example of an upside down e-test, and so it doesn't work when you put it down upside down. That's okay. Here, and this is the final one. So this is meropenem. So this last isolate is a gram-negative. You see that there's sort of an inhibition zone, but there are colonies that are growing inside the inhibition zone. And so this is an example of an isolate, and there are many examples of this that kind of displays heterogeneous resistance. And so there are some parts of the population that are susceptible and some parts that are resistant. And so because you have those little colonies growing within the zone of inhibition, the conclusion of this would be that the MIC for this isolate is greater than 256 because you have those isolates growing inside the zone. This particular organism happens to be one of those CRE organisms, so a carbapenem-resistant Enterobacteriaceae, and happens to be a Klebsiella pneumoniae isolate. And so because it is resistant to carbapenems, predictably meropenem was not an option for this isolate. So I guess without knowing it, on Monday you were either working with staph, E. coli, Pseudomonas, or CRE when you were doing your MICs. Again, as long as you're using appropriate protective precautions, the risk of working with any of these organisms is fairly low, actually. So hopefully no one's been feeling feverish since Monday. I actually once had a student I was working with who was working with salmonella, and he had a syringe full of salmonella, and he scraped his finger with the needle and actually broke the skin, but in the end nothing happened actually. And so he just washed it really well and nothing happened. I've been working in the lab a couple of times where I've been working with gonorrhea, and there was one time when I was working with Neisseria gonorrhoeae, and I had a swab that had a mixture of saline and Neisseria gonorrhoeae on it, and I had a plate in my left hand, and I dropped the plate, and reflexively my hand kind of went like that. And this big drop of Neisseria gonorrhoeae hit me on the forehead, and I just washed it off really well. And so I think one of the points is that working with these things is fairly safe as long as you're using appropriate precautions. All right, so that said, let's go through just a few examples of these. So I'll ask you to shout out what you want to use to treat these patients, and then we'll go upstairs and quickly look at your MICs. And so here we have a 67, so you don't have these slides, by the way, I'm sorry, this was a kind of last minute addition. So you have a 67-year-old male, hospitalized for 3 weeks. He's in the ICU on a ventilator. He's received 2 different antibiotic courses without any clinical success. Has a pre-existing seizure disorder, receiving anticonvulsant therapy, also has renal dysfunction. So anyone want to suggest what they would want to use as their therapy for this person and why? You can't leave until you give me some answers. All right, yes, thank you. Cefepime. Okay, and why did you choose that as opposed to meropenem?
Because it could cause seizures and seizures.
Right, so carbapenems are often going to be causes of seizures, and so in the grand scheme of things, you probably want to avoid a carbapenem in this person. You're right. So yeah, cefepime would be a perfectly good option. Any other answers? Anyone else want to do something different? Anyone think that's not a good answer? So technically, based on MICs, you could use any of them, right? Any concern with tobramycin? Any other pre-existing conditions that would make you concerned about using tobramycin? So renal dysfunction, so it doesn't mean you can't use tobramycin, but perhaps it wouldn't be the best idea in this scenario. So Again, though, this is one of those easy cases where you could use any of these theoretically. Again, minus looking at patient-specific factors and other things like pre-existing conditions. But these are all, or the isolate is what we would call pan-susceptible, and so no resistance seen here. So case 2, a 31-year-old male with sinusitis, has heart disease and hyperlipidemia, receiving amiodarone and simvastatin. Also has a penicillin allergy to which he reports hives. Anyone want to take a shot?
Those can cause QTC prolongation.
And he has amiodarone. That's he has a moxillion allergy. Why would you go with that?
Someone be brave. Remember, we're going to have that short day potentially, but
Sulfamethoxazole. Bactrim.
go for it.
Bactrim.
Bactrim? Okay, why? Couldn't quite catch most of that. But did you say it has a very low? Right. So you're definitely not the first person who said this, so don't feel bad. But it's an MIC, and so don't avoid saying you said MIC, right? Okay. So it's an MIC, not a MIC. You're not the first person who said that, though. So TMPSMX, yeah, the isolate is susceptible to TMPSMX. The person has no contraindications really that would make you worry about TMPSMX, right? So would amoxiclavulinic acid be an okay choice in this person?
Nope.
Why not?
Penicillin allergy.
So penicillin allergy, hives indicating a type 1 IgE-mediated reaction, so you're going to kill the person if you give them amoxiclav, potentially. What about ampicillin?
Doesn't work anyways,
So
but no.
same thing,
Penicillin
plus the
allergy.
isolate is resistant to ampicillin. Ceftriaxone,
No,
probably? Probably not. Why?
because it's a beta-lactam.
So cross-reactivity from an allergy point of view, the risk of cross-reactivity is quite low, but do you want to mess around with that if someone has a type 1 allergy? No, you rather would not. Erythromycin, why didn't anyone want to go with erythromycin?
QTC.
So QTC prolongation, amiodarone, the big red flag drug to look for. Erythromycin also has some CYP induction of 3 and 4, or rather inhibition. Chlorithro, intermediate resistant. You haven't really learned this specifically yet, but chlorithro doesn't really get particularly great concentrations in the sinuses, so it wouldn't be one of those drugs where you could allow for the higher concentrations in the tissues. Cipro, QTC, Levo, QTC, right. So really, TMPSMX is pretty much the only great option, I would say, so correct with it. So case 3, 78-year-old female with a urinary tract infection, taking a daily aspirin and a daily multivitamin.
If she spaces from the multivitamin, she can take that time. Sulfamethoxazole. Or the nitrofurantoin should be fine. Oh, never mind, the TMS is high, so yeah.
Okay. Nitrofurantoin, okay. Why do you choose that?
Because isn't that indicated for UTIs along with Bactrim, but but Bactrim is I, so nitroglycerin is susceptible.
Yeah, so you know, as I mentioned, TMPSMX is one of those drugs where in the setting of a UTI, seeing that intermediate result, you probably could still use Bactrim, but why use Bactrim when you have an S next to nitrofurantoin, which is equally useful for UTI. So nitrofurantoin would be one good option, certainly. Were you going to say something different? Cipro, yeah, Cipro would be a fine option. Gets really good urine concentrations. Anything you'd want to tell the person if you decided to use Cipro? What's that?
I mean, there's a black box warning for tendon rupture.
Right, so yeah, actually, and are you concerned about that in this person? Because of...
No, just black box warning.
I mean, she is actually, this is an older patient, so actually, from that point of view, you would be more concerned with tendon rupture with a quinolone. That's actually a good point that I hadn't thought of. So it still would be a good option, I think, but you'd want to be careful about that tendon rupture issue. You're right. What else would you want to tell the person if you gave them a quinolone? So spacing with their multivitamin, right? So just to avoid binding. Phosphomycin. Anyone want to use phosphomycin in this person? So that would be another perfectly reasonable choice. The isolate is susceptible to phosphomycin. Moxifloxacin? No. So again, why? Right, so just for PK reasons. And so the isolate is definitely susceptible to Moxi, but if you gave Moxi, you wouldn't get adequate urine concentrations. And realistically, actually, if you had, I mean, when we do these MIC panels, you can, it's not like you test every single drug against every single organism. And so there also are site-specific MIC panels. And so realistically speaking, if someone had a urine sample and you were running MICs, you wouldn't even run moxifloxacin. So this is kind of a fake from that point of view. So. And then just a couple more quickly. So a 43-year-old with ventilator-associated pneumonia, receiving methadone, aspirin, lisinopril. So any reason that you couldn't use amoxicillin clavulanic acid? Not really, right? Susceptible. We have a streptococcus pneumonia isolate. So what is the fact that that isolate is resistant to amoxicillin but susceptible to amoxicillin clavulanic acid tell you about mechanisms of resistance that are present? Right, so this isolate is producing beta-lactamase enzymes, and so the clavulanic acid inhibits those beta-lactamase enzymes, and so gives you activity. Anyone want to go with ceftriaxone, or is there any reason not to go with ceftriaxone? Not particularly, really. Ertapenem. Is there a reason, perhaps, not to use ertapenem in this scenario?
Broad coverage.
Right, so it's, again, that scenario of bombing an ant with an atomic bomb, basically. So much broader coverage than you would need in this scenario because you know your MICs, and so you're not in that empiric phase of therapy, so you can pretty much stay away from using ertapenem. Anyone want to use vancomycin? The vancomycin would be more of a drug that we would reserve for resistant pathogens and something so susceptible to a lot of different drugs. You want to save vancomycin for other things, basically. Levo and methadone is a bad combination. Erythro, it's resistant, but erythro would also be a bad combination with methadone. And then Clinda would be a perfectly fine option as well. TMPSMX really wouldn't be a very good option with that intermediate result. So last one. So a 23-year-old female with community-associated pneumonia will be treated as an outpatient, penicillin, shortness of breath, receiving a daily iron tablet, also receiving fluoxetine, also receiving procainamide. So if it helps you, you don't have very many actual reasonable choices in this scenario. So let me know when someone wants to guess at an answer or tell me an answer now.
Levofloxacin.
Actually, really, there's only one correct answer to this question. So I have one linazolid. Any other guesses? So linazolid's not correct, unfortunately. So any other guesses?
Levofloxacin.
Yeah, actually, I'm sorry. There's, well, no. Levoprocainamide, so additive QTC prolongation,
Oh, yeah.
probably not a good combination as well. Linazolid, by the way, why avoid linazolid? So fluoxetine, so you have that contraindication there. Again, if this person were being treated as an inpatient, you wouldn't worry about that, but we've said they're going to treat them as an outpatient, so you have the risk of serotonin syndrome. So amoxicillin?
No.
No. For two reasons, right? Resistance and allergy. Amoxiclav?
No.
No. Traxone?
No.
Why?
Cross-reactivity.
Right, cross-reactivity. Ertapenem?
No.
Cross-reactivity. Vancomycin?
No.
Outpatient, right? So, I mean, I guess you could, if you really tried to stretch it, you could try to give vancomycin as an outpatient, but not something that you'd want to really do. So that would be kind of a right answer, I guess. Erythro?
No.
No. From a drug interaction point of view, hand resistance. Levo, the drug interaction with procainamide. Linazolid, drug interaction with fluoxetine. TMPSMX is I, and so Clinda becomes your only good option in this person, really. And so oral Clinda, which often gets ignored, is the only appropriate therapy for this person. So we'll go upstairs next. It shouldn't really be too long. Probably going to get in trouble for having such a short day, I think. But
we won't tell.
You'll have to put gloves on again. You don't have to gown up though. So I'll meet you all upstairs.